Out of all the anxiety disorders that millions of people around the world have been diagnosed with, none arguably carry the same amount of suffering as those with obsessive-compulsive disorder. People with OCD typically engage in rituals that are designed to lessen or eliminate worries, fears, and/or anxiety. Other, less obvious forms of OCD take place entirely in the mind, in the form of harmful and distressing thoughts, which usually turn into obsessions. Most cases of OCD can have a negative impact on a person's well-being and life. The disorder afflicts about 1 to 3% of the pediatric and adult populations. The good news is that there are many treatment options available to deal with this disorder, such as cognitive behavioral therapy, medications, neuroimaging, and neurosurgery. The patient's quality of life can greatly impact treatment, especially in interactions between family and friends. Though inconclusive, there is mounting evidence that the level of family accommodation for an OCD patient can certainly impact treatment outcomes. OCD can disrupt a patient's life at all levels, be it social, personal, or professional. Less obvious and noticeable is how family members can be affected by the disorder. Their support during the patient's plight can influence how severe the disorder can be. This concept is referred to as family accommodation. For the scholarly journal Expert Reviews, Dr. Eli R. Leibowitz and his team define family accommodation as, quote, ways in which family members take part in the performance of rituals, avoidance of anxiety-provoking situations, or modification of daily routines to assist a relative with OCD, unquote. Examples of family accommodation are not throwing things away, hoarding, opening doors for the patient, fear of contamination, buying extra hand soap, excessive hand washing, and reassuring the patient, intrusive thoughts. Preliminary research has linked family accommodation to the severity of OCD symptoms, especially in children as well as those patients with a concurrent condition such as anxiety and depression. However, this information hasn't proven to be definitive. There is even less information available on the effects of family accommodation on adult patients with OCD. Until further research is conducted, the best way to avoid accommodating the patient is to educate yourself on the disorder and its underlying causes and effects. Cognitive behavioral therapy, or CBT, has been proven to be the most effective treatment for people of all ages with OCD. The addition of serotonin reuptake inhibitors, SRI, with CBT is quite effective than with just the medication alone. According to specialists Lindsay Brower, Adam Lewin, and Eric Storch, who write for Mind and Brain, the Journal of Psychiatry, CBT is, quote, an empirically supported psychosocial treatment premised on the theory that an individual experiences significant distress in the presence of a previously neutral thought or stimulus that has become classically conditioned to signal distress, unquote. It is a step-by-step process where the patient is educated on what OCD is. The patient learns that the very compulsion that they think will prevent disaster actually makes their symptoms worse. Next, the patient is put in a situation that triggers an anxiety compulsion. The patient is not allowed to act on this compulsion. Over time and practice, the compulsion cycle is reduced significantly, if not eliminated. There are various things to consider before undertaking CBT treatment. 2/3 of all adults and children with OCD have one or more concurrent conditions, such as general anxiety and depression. This can obviously affect the treatment outcome. Modifications to CBT, such as motivational interviewing and cognitive therapy, have shown varying levels of success. Access to this treatment can be difficult, mostly due to location and financial woes. Thus, many options have been provided, such as intensive treatment daily over a few weeks, computer-based treatment communicating via webcam, manualized treatments, and self-guided therapy. The advances in medicated treatment for OCD have progressed strongly since the mid-80s. Many tests and trials of selective serotonin reuptake inhibitors, SSRIs, and the treatment of pediatric OCD in the ensuing years has proven promising. However, it wasn't until the early 2000s that a comparison study of these numerous SSRIs in the treatment of children with OCD was conducted by specialists. The number of studies and trials in minors with OCD is smaller than that of adults. This is most likely due to numerous concerns over testing children. The four most common SSRIs prescribed to OCD patients are Prozac, Zoloft, Celexa, and Paxil. It usually takes some time to find the right medication for a patient. SSRIs work most effectively when taken concurrently with CBT. It is a well-known fact in the psychiatric community that CBT, as well as exposure and response prevention, are the best treatments available for people with OCD. An unexamined but noteworthy, quote, outcome component, unquote, has been acknowledged: the patient's quality of life. According to their research in the publication Annals of General Psychiatry, specialist Elizabeth Hertenstein termed that quality of life, as defined by the World Health Organization, is, quote, a multidimensional construct describing an individual's subjective perception of their position in life in the context of the culture and value system in which they live, and in relation to their goals, expectations, standards, and concerns, unquote. Most patients describe feeling a reduced quality of life in most areas, such as social, physical, global, and environmental. Even when improving with the proper treatment, patients' quality of life levels are still much lower than standard quality of life. Thus, it is important that specialists continue their research and provide as many options as possible for those who suffer with OCD. Most patients with OCD respond favorably to conventional and first-line treatments such as behavior therapy and SRI medication. However, a small percentage doesn't respond to these interventions. At this stage, when a case of OCD is severe and intractable, patients and physicians can consider if they are, quote, eligible for novel neurotherapeutic interventions, unquote, including ablative procedures, radiosurgery, and deep brain stimulation. Ablative treatments create lesions at particular parts of the brain. These procedures all work to hamper activity in different but vital areas like the anterior cingulate cortex, frontal lobe, the limbic system, and the thalamus. Radiology, which uses wide knife technology, is a procedure that has been improved to the point where smaller and more precise lesions can be made, thereby removing the need to perform a craniotomy, which is quite risky. A recent treatment to emerge on the scene is deep brain stimulation, a refined alternate option to ablative treatments. Electrode contacts are placed on the patient's skull, while adjustments are made by a trained psychiatrist in regards to electrical current polarity, voltage, and frequency. Research is currently being conducted to refine these programs to achieve the most successful patient care outcome. These treatments can be invasive and costly, however, and should only be considered as a last resort. Neuroimaging predictor studies can be very helpful to determine the best selection of patients, as well as provide adjustments to a treatment on a per-patient basis. In the treatment of OCD, there are many options available. When something doesn't work, a modification can be made or another option can be tried. Patients with OCD can take solace in the fact that their disorder is one of the most heavily researched in the psychiatric community. New discoveries and conclusions are being made constantly. With the support and understanding of family and friends, as well as the help of CBT and SSRIs, the patient can return to having a normal, thriving, productive, and fulfilling life.